Okay, did it give everybody a warning, or maybe it doesn't do that? Well, hi, everybody. I'm Sarah Clute-Bain. I'm the Boone County Hospital Foundation Director, and we are here today with our most recent Educating and Empowering You program that I'm really pleased to present through one of our very own employees, Addison Enns. Today will be sharing with us about advanced care planning and preparing for the unexpected. So she's our licensed social worker here at Boone County Hospital. And before I dive into, or she dives into her program, I just want to really quick give an update from the foundation side of the world. We are going to have no program in August. So no program in August. Typically, that's what we have found is best because a lot of people take vacations in August and it's kind of hard to sometimes locate a speaker for the month of August. So we will not have a program in August, but then we'll come back in September and we'll have Shiloh Burke with integrated insurance. In October, we'll have some of our women's women's health is the topic, and hopefully our very own providers here, family practice doctors, Hay, Lincoln Meyer, and Stevenson, and or at least some of them available. And then in November, Restorix, who runs our wound clinic, the hyperbaric chamber, they will be providing a program on diabetes education. So we have a great lineup coming up here in the next few months. And without further ado, I will turn it over to Addison. Addison has a lot of great information for us today. I will suggest that if you do have questions, you want to throw them in the chat, feel free to do so. I know that Addison has a plan to attack those questions as they come up or at the end. So I'll turn it over to you to get started. If you want to share your screen too. I know you have a presentation. So.
Yep.
And tell us about yourself too when you get started, if you don't mind.
Sure. Yeah, I'd love to.
Great.
Just make sure and let me know when this is up and going.
Yeah, there you go.
All right. Is it good?
Looks great.
Okay. So like Sarah said, I'm Addison Enns. You can call me Addie. I am a licensed master social worker here at Boone County Hospital. I was just recently hired in April, so I've really been enjoying my first few months here. I do have about now 6 years experience with hospital social work. For the other 5.5 years, I was at another critical access hospital. So all of my hospital experience is within the critical access hospital setting. So I graduated from Northern Iowa with my undergrad, and then I got my master's online through the University of Southern California and obtained licensure directly after graduation there. And I've even since obtained certification in specific to healthcare social work. Just my goal with that is to let everybody know who I'm serving, that I'm dedicated to the healthcare side of social work, and I really have a passion for it. So. Speaking of passions, advanced care planning is a big passion of mine. The term advanced care planning can be kind of confusing for some. It's basically just another way of saying, we're planning for the future. Advanced care plan or advanced care documents are like your living wills, your power of attorneys, and those kinds of things. So that's just what we're going to talk about today. So who all should be a participant in advanced care planning? I always advise everybody 18 years and older. The reason why 18 years and older is because once you turn into an adult, you are now your own caretaker, your own decision maker. So unless somebody else is designated as your legal guardian or decision maker, then you get to make those decisions yourself, which is why I advise anybody who turns 18 or older at least start thinking about advanced care planning and how you would like your wishes to be set for the future. So what exactly is advanced care planning? So like I have here, for those of you who can see my slides, it's planning for future medical care. I know that sounds a lot, easier said than done. Basically what we're doing is planning for future medical care that you might receive during a time when you can't actually express your wishes. So for instance, if you have a health emergency such as a stroke and you're not able to tell us how you feel or what your wishes are, by completing this process, we would be able to abide by your wishes because we'll know what kind of care that you have asked for. So where should you do advanced care planning? You can do it anywhere. You can do it at home, you can do it at your attorney's office, you can do it here at the hospital. Um, One thing that I personally, and I don't know if this is biased because I'm passionate about it, I prefer you do it within the healthcare setting. Nothing against our attorney friends out there, but as healthcare providers, we are trained to assist with folks making these decisions, and we can actually help guide you down the path that you want to go. Um, so that's just a little tidbit of advice there. And when should you do advanced care planning? Now, 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 now. It's never too early, except for if you're younger than 18. So um, do it now. If you think that because you're only 45, you don't need to think about your healthcare wishes for the future, you're wrong because we aren't promised tomorrow. We don't know what's going to happen. You could have a traumatic injury that leaves you in a coma. And if we don't know how you want to be treated, then we have to rely on others to give us those answers. And why do we do this? Basically, what I've kind of already preached is so your wishes can be granted. We want to make sure that we are treating all of our patients and loved ones with the care that they want to have. If a person does not want to be treated a certain way, we don't want to treat them that way. So it's just important to have your wishes known to your family, your friends, your loved ones, whoever's caring for you, and then especially your healthcare providers. So there's some top recognized advanced directives in Iowa. So there's that word again, advanced directives. That's looking at your medical power of attorney, your living will, and then I've also added one called the I-Post. So these are the three top recognized advanced directives that we use in the state of Iowa, and I'm going to go through each one of these. So the first one I want to go over is the medical power of attorney, also known like when you see the legal document, it's the durable power of attorney for healthcare decisions. Much easier to say medical power of attorney, or you might see medical POA or just POA. So this document is specific to designating a decision maker for you in case you come upon a situation where you're not able to make a decision for yourself. So on this, for those of you who can see this document, it looks like a lot, and it kind of is, but you truly just have to designate at least one person who you would like to be your decision maker, and fill that in this area. And then it does have to be signed by the decision maker. So if I'm the patient and I want to designate my sister as my power of attorney, then I'm going to put, I hereby designate my sister's name on here. And then I can also do like a secondary power of attorney in case that primary is not free or has passed away or is just not willing to make that decision. If they want to pass that down to the secondary, then they certainly can. And then it would have to be signed by me as the patient or it's called the principal, which is the person granting the power of attorney. With this document in the state of Iowa, and this is for all advanced care planning documents except for the I-Post, it does have to be either witnessed by two separate people or notarized. So you'll see on here, there's two different places to have witnesses. And then actually there's a back of this document. I just didn't want to put the back on here. On the back is where, oh, actually, no, it is on this one. I'm sorry. The notary public can sign on this one. I was thinking of the combined document. So you can see everything on this page where you can either have your two witnesses or your notary public. In the state of Iowa, you just have to have one or the other. You do not have to have it witnessed and notarized. So often when I do these with folks at the hospital, we do have a lot of maybe all of our house supervisors do have the ability to notarize. So when we complete these with folks here at the hospital, then we just have it notarized here at the hospital and it's a legal document before they leave our doors. So this next one is our living will. In the state of Iowa, it is called the Declaration Relating to the Use of Life-Sustaining Procedures. So this document is extremely common, might be extremely familiar to those who can see this. It basically is just stating that if you have an incurable or irreversible condition that will result in either death within a relatively short period of time, um, that you would not like to have any life sustaining procedures. So this document serves similar as far as signing it to that power of attorney document. The patient themselves has to sign this document, and then it does have to be either notarized or signed by two witnesses. So this document is where most people would sign it if they are not interested in having any kind of life support, such as ventilation or any aggressive measures that are going to sustain their life if they are in a situation where they're not able to make that decision. So like I used the example earlier, if someone's had a stroke and they're unable to make that decision themselves and it looks like that they're going to be on um, some type of a machine for the rest of their life, then this might be something that they would use, and you just plan for that. So this document does not technically serve as a do not resuscitate, though it is very similar. It is not the same thing. And then I do want to point out that the power of attorney document that I just went over, this one, and the declaration, the living will, there is also a combined document where you can actually do both of these on one document, and it looks just like this. It's just got all of that information on one page. Okay, so the iPost is it's fairly new within the last not even 10 years. Um, the state of Iowa had started recognizing it in the last several years. The iPost stands for Iowa Physician Orders for Scope of Treatment, and there is a different version of this document that is used from state to state. However, this is Iowa's version. So this document is not deemed a legal document. It is not notarized by anybody. It is only signed by a patient and then by the physician who is who is overseeing these wishes or who is in agreement with the wishes. So what this document entails is a little bit more decision making than the other two that we went over. You can, for those of you who can see my screen, that first section is discussing cardiopulmonary resuscitation. So this is if the person has no pulse and is not breathing. This is where you would decide if you were in a health emergency. And again, I'm just gonna use some specific examples. So if you go into cardiac arrest or something, this is where you would want to have planned out if you want to have CPR or not. So it's very clear cut there. You can check whether or not you want CPR or attempted resuscitation, or if you would like to be what's called a DNR, which stands for do not attempt resuscitation. The second the second box down is called medical interventions, and this one is to serve more of a purpose if the person or the patient has a pulse and or they are still breathing. So this is typically where I use the example of having a stroke. If I were to have a stroke right now, what would I want for my treatment to be? And this is where I would really choose that. So I actually like to start at the bottom. You can decide to have that full treatment where you're going to have CPR, you're going to be intubated, you're going to have that mechanical ventilation if necessary. You're basically going to have all of the aggressive measures needed to try to save your life. The next box, that middle box, is called limited and additional interventions, and that includes um, basically anything for comfort, but also includes medical treatment, such as using a cardiac monitor, oral and IV fluids, and other medications as needed. Something important to notice about this one is it does not include intubating or using mechanical ventilation. Um, and it does also include transferring to the hospital if needed for more critical care. So the very top box, which is actually the first listed box in this area, is called comfort measures only. And this is a box that a person would check if they were only wanting to have medications to keep them comfortable. So you're not going to have your IV antibiotics and all of these aggressive medications to try to cure an illness or a health emergency. It's really just measures taken to keep a person comfortable. So if that person does not look like they're expected to survive or they're just in really, unfavorable shape, then that's when we would just be using like pain management, oxygen for comfort, suctioning, those kinds of things. And oftentimes when someone checks this, they prefer to not be transferred to a hospital for life-sustaining treatment. So for instance, if an individual is in the nursing home and they have checked that they would only like comfort measures, then if they were to have a health emergency such as that stroke, then staff would look at that and say they prefer not to be transferred to the hospital for life sustaining treatment. At that time, they would just need to do comfort measures at the location where the individual is at. So for the third and the last decision-making box here is artificially administered nutrition. We always make note that we offer food by mouth if possible. And this is where a person chooses whether or not they want a feeding tube. So whether that's a feeding tube in the abdomen or an NG tube um, down your nose and your mouth. So a person can check if they would like to have a long-term artificial nutrition tube at that point if they would just like to try one. And you can even make note in there if say, hey, I want to try this for a month or I want to try this for a week, see if this works. And then of course you can choose that no, I do not want any artificial nutrition. And then in the bottom, we just choose, who was this directed by? So if I'm the patient and I'm the one giving this direction and these decisions, then we would check patient. If the patient is unable to make decisions and it's a healthcare power of attorney that's making the decisions for them, then that's what we would put, as you can see. And then for the rationale for these orders, you just put whether or not that's what we know is the patient's preference or if this is their advance directive. They might not have any other advance directive stating their wishes, so this would be their only advance directive. So this document, like stated in the title, is actually a physician's order. So it is going to be signed by the patient, but then the physician or nurse practitioner or PA will actually sign this as well to put it in effect. And then there is a backside of this document that allows for you to put a surrogate decision maker, which would be similar to your medical power of attorney, as well as another area to list another healthcare professional who helped prepare the document. So for my position as a social worker, I actually help folks with these a lot, and so I would sign my name on the back where it asks for the other healthcare professional who assisted with filling out the document, and then the provider and the patient sign the front. The thing about this document is this can be used in and out of the hospital. So we like to send this piece of paper home after it is signed by the patient and the provider. Like to send it home on a nice bright sheet of paper, whether it's pink, orange, bright yellow, bright green. And then I always recommend putting that document where it could be seen by emergency medical services or law enforcement so that those individuals can also see the wishes if they have to arrive and perform medical treatment on an emergent basis. And then of course we make copies and put it in patient charts. It is recommended to have the original document with you if you go to the hospital or if you go to the nursing home. However, it is extremely unlikely that you're just walking around carrying the original document with you. So we always like to make copies just to make sure that we have that. So those were the three most common or traditionally used documents in the state of Iowa. So here I just kind of want to talk about making an informed decision. As a social worker, I just it is my absolute desire to make sure that everybody who makes a decision about their health care is making an informed decision. And what I mean by that is I want you to have all of the information available to you before you actually decide what you're going to do. So here I've just noted to have a detailed discussion with your primary care provider or other teams of your healthcare team regarding any questions you have about end of life decision making. And then just some little quote unquote fun facts I have. These are certain things that I'm particularly passionate about. So, did you know that the overall survival rate of CPR in adults is 10 to 20%, which might include permanent brain damage as well as other irreversible trauma? A lot of people don't realize just how low the probability of successful CPR actually is. And then also, did you know that chronically ill and elderly individuals have actually less than 5% chance of surviving long enough to leave the hospital after receiving CPR? So if we have a chronically ill elderly individual, say they've got COPD, CHF in the hospital, and we have to perform CPR, this statistic is telling us that they have a less than 5% chance of surviving long enough to actually leave the hospital. That's a really low number, which I really like to stress when folks are making their decisions. That way that they are aware of what the chances are of leaving the hospital after you put your body through that kind of trauma, because it is a very traumatic experience. Also, did you know that roughly 40% of American adults have completed an advanced directive? And 90% of those who have completed advanced care planning documents have had their end of life wishes met. Of course, we would love to see that number be 100%. I mean, that's obviously not happening, but 90% is really good. If you have completed one of the documents that I just reviewed, or if there's another one out there that you have reviewed and it is recognized in the state of Iowa, if you've completed that, there's a 90% chance that your end of life wishes will be met, which is always, always, always our goal. I don't think patients and family members realize what kind of goes on behind the scenes when we're trying to track down this kind of documentation. It is so unbelievably important that we know a patient's wishes before we provide them treatment. That way we know that we're not infringing on their rights or what they would want us to do. So I do have some commonly asked questions, and I neglected to say this at the beginning. So if you have any questions that you're jotting down, I'd be happy to answer them. But I did want to just run through these commonly asked questions, and so I'm going to ask them and answer them. Um, so my first question is, when does an advanced directive get used? So when does that living will and or your medical power of attorney actually come into play? So these documents are always important to have in your chart. They do not actually get enacted until a person is unable to make that decision for themselves. So for instance, the medical power of attorney, it's nice when our friend Betty's son Joe has the medical power of attorney for her, but as long as Betty is able to tell me what she wants and she's able to make that decision herself, then um Joe's ability to be the power of attorney doesn't really weigh a whole lot legally. It will only be truly effective if Betty is unable to make decisions for herself, and then that's when he steps in and is designated as that decision maker. Obviously, we always ask for familial support or loved one support, but legally, that's when it gets used. So the next question, can an advanced directive be overridden? So technically, yes and no. So if an individual sets up an advanced directive, such as a living will or this I-post, it can be overridden by a medical power of attorney. So it's extremely important that when you are designating your power of attorney, and I'm going to get to this in another question, when you're designating your power of attorney, make sure that that individual knows your wishes and knows how important your decision making has been. And hopefully that person will respect that, because ultimately your medical power of attorney will have the say in what happens with your care if you're unable to say. So what happens if you experience a health emergency and you don't have an advance directive? So in this situation, we would typically have to treat you as as though you want all measures taken. So if someone comes in and goes into cardiac arrest, if we don't have an advance directive telling us not to, then we would treat that person as what's called a full code. So we would need to be performing every measure that we could to try to resuscitate that individual. If a person has an advance directive, but we don't have it in their chart or we don't have it, accessible to us, it truly works the same way. If we don't have any way of knowing what that person's wishes are, then we will treat that person as though they wish to have all measures taken to save their life, which is again why I express the importance of making sure that if you have this documentation done, make sure that your healthcare providers have it, make sure that your family members have it, make sure that everybody has it who might take charge of your care. So, what if I change my mind about my end of life wishes stated on my advance directive? That's no problem. People change their mind all the time. Um, the what you really need to make sure that you do is complete a whole new advance directive. We don't correct them. We don't white out anything. We don't scratch them out and initial our name saying, "Hey, we changed this." We truly need a whole new document. And then if we were to have two documents in the chart saying, Betty completed this iPost back in 2018, and this says that she was a full code, but then she completed this um, iPost in 2021 saying that she chose not to be resuscitated. We would go by that most recent document because it does have it has the most recent date with the most recent wishes on it. We do like to void those out, write void on them if you can. Know that that's not always a possibility, especially if your documents are at, you know, 10 different offices or hospitals. Excuse me. So, what if a medical provider does not agree with an advance directive? So I've never really seen this happen. If your treating provider does not agree with what is stated on your advance directive, then simply find a provider who does agree with it. You have the right to find someone who's going to treat you with dignity and to treat you the way that you want to be treated. Like I said, I've never encountered a provider who was not willing to um, go in line with what a patient's wishes were, but it does happen. So does a DNR or do not resuscitate mean the same thing as do not treat? I have found that this is a huge concern for people, which is often why folks tend to desire CPR as late into their age as they do sometimes. We've got, 85, 90, 95-year-olds who still desire to have CPR because they're afraid that if they change their mind to be a DNR, that means we're just going to stop treatment, which is absolutely not what that means. That DNR only means if their heart were to stop or they were to stop breathing, that we would not resuscitate them. It does not mean that we are not going to treat them with antibiotics and do chest x-rays and all of those things in the hospital. So who should I choose to be my Medicare? Oh, I'm sorry, I put Medicare, medical power of attorney. Um, like I touched on this just a minute ago, you want to choose somebody who you know is going to respect your wishes. So an example that I would choose or that I would give is that if mom has two kids and she's trying to decide who she wants to designate as her medical power of attorney, she's going to probably automatically want to choose the oldest kid. But ultimately, what you're really going to want to do is choose whichever person is more likely to go with what you want. So if you've got a family member who you would like to be making decisions for you, however you feel like they're actually just going to make those decisions based on their own wants and needs, they're probably not going to be your best decision for a medical power of attorney. You want somebody who's going to be able to stick to the facts, stick to your wishes, and ultimately kind of detach their emotions from the issue. So where is the best place to keep my advance directive? Do not keep it in your safety box at the post office. That is the worst. That is the last place you should keep it. Yet that is the most common place that I hear people keeping it. Don't keep it locked up somewhere where no one can find it. The best place to keep your advance directive is going to be in your medical chart at the hospital, at your doctor's office, um, any with family members. Make sure that you've got copies in your own home where it's easy to find. If you've got like a special folder, make sure that anybody who needs to see it is going to be able to see it. Because if you come to the hospital and we don't know what kind of care that you want, and your wishes are tucked away in your safety deposit box at the post office, we can't do anything about that. Sorry, that was a little soapbox, but that's kind of a rant because a lot of folks do that, and we just want to make sure that we've got ease of access to those documents. So, do I need to wait for my medical provider to initiate advanced care planning? Absolutely not, which is a lot of the reason why I'm doing this presentation today. Don't wait for your medical provider to initiate advanced care planning. Although it is their job to talk with you about it, it is not necessarily their job to make sure that you're doing it, to make sure that you have your documents in place. It is their job to, talk with you about it, educate you on it, but they're not going to necessarily hold you accountable. So don't wait for your medical provider to initiate advanced care planning. Like I said earlier in the presentation, do it now. Just don't wait, just do it now. And are advanced directives legally binding? So the medical power of attorney and the living will documents are medically or legally binding as long as they are notarized or witnessed by two people in the state of Iowa. The I-post is not technically a legally binding document. It is a physician's order. Um, I wouldn't necessarily want to take that up in court, but that's according to the state of Iowa. So yes, advanced directives are legally binding with exception to that I-post that is a physician's order. So those are the questions that I have listed and answers that I've given. Here's just a couple of resources where I got some of the statistical information, and I do use that statistical information a lot when I'm talking with folks. I do weigh heavy on that information because it really paints out a good picture. Um, so I can actually stop my presentation here and hop back on if I know how to do that. Sarah, do you want me just to stop sharing it?
If you want to, or if you want to put back up your, just like your information, because that's one of my
Okay,
questions, actually.
absolutely. Oh, I just totally X'd out of it, I think. Yep.
It's okay. If you didn't,
Nope,
we
that's
can,
fine. It's right here.
awesome. Um, so yeah, I mean, I had just a couple of questions, and maybe you really explained this pretty clearly, and I missed it, but when you were talking about the I-post not being legally binding, can you talk a little bit more in detail about that and what that really means in terms of not being legally binding? Like, obviously, is there, I mean, like, why would it not be legally binding, for example, or kind of looking at it from the other side of the coin, so to speak?
So it's technically not considered legally binding because it's a physician's order. It's not an advanced care planning document that is notarized or witnessed to make it a legal document. So because it's not considered like a living will, it's not considered a power of attorney. I can do some more research on that though and answer additional questions. I don't know a ton about how well that stuff would hold up. um I like to mention that because if I've seen where a patient comes in and their I-post says this, and then their family members say, oh, but they've actually told me this, and their power of
Mhm.
attorney is able to make that decision. um so it can get kind of sticky, which is also why I just really reiterate, make sure that your loved ones know exactly what you want for your decision making and for your wishes, so that they can prepare for that and so that they're not stuck making decisions themselves.
Mhm.
But I know that kind of just went off the beaten path there, but that's my knowledge on the subject as far as why that's not considered a legal document.
Yeah, and that really does. I mean, it makes sense to me. I just was curious also, like from the perspective of if something is not along someone's wishes. I mean, do you ever hear much about like people, having issues with that or how?
No, no. I mean,
You
I always like to prepare as if it would happen, but I've never run into any issues whatsoever. with
Mhm.
that. And as far as stuff like that going to court, I've truly never in any experience had any issues with that.
Yeah, and it's kind of like what you were talking about, that you're going to treat someone on all levels if you don't have the information from them. They're just, it's automatically going to be that you're going to resuscitate, you're going to do all the measures to keep them alive. And I guess from my very basic standpoint, I look at, or I consider, like the Samaritan law, good Samaritan laws that
Hmm.
um, cover maneuver somebody who's, choking, that type of thing. I mean, does that kind of connect there a little bit in a
It
small way?
it can, and like I said, I wish I knew. I need to do some more research on that because that I know that that is one thing that I've heard from like nurses or physicians who are out, if you're at a baseball game and someone drops in cardiac arrest, and if they're not a DNR but we don't know it, and here we're performing full CPR, what risks do you run being sued for touching that person? I mean, it can get very messy. Um, so I guess we just always hope that we don't we don't find ourselves in those situations. But that is something that I do need to do more research on. Um,
Yeah.
it's
Well,
the out of hospital stuff I'm not quite as familiar with as far as the legalities of it.
yeah, absolutely. And I'm really putting you on the spot in that
No, you're
that
fine.
capacity, but
You're fine.
I'm just my wheels are turning over here just a little bit, so I'm just
Yeah.
curious about that. And then a couple of other things. So you talked about documenting with you, like going through these documents with you. So can you tell us just a little more detail about that? Is that always just somebody who's here in the hospital, or a patient, inpatient, outpatient? Can somebody call and just make an appointment with you from, like, that lives in Boone County? Like, how does that work exactly?
So as of right now, so this is a billable service. So since I am a licensed social worker, I do bill for this service on an inpatient level. So if I do complete any advanced care planning with a patient, I do have to get their consent prior to doing any of the education, counseling, documentation completion because that does get billed to their insurance. That's where we stand right now for inpatient. And since I am still so new here, we haven't worked through to the outpatient stuff yet. With that being said, I'm happy to give any kind of guidance. And at this point, I'm really happy to help anybody complete these, even while we're trying to get the outpatient stuff figured out. I just really documentation on my end, indicating that it was completed is also extremely important, which is a lot of the reason why I've been waiting for the billing process so I can complete it as an outpatient. And if I'm able to do it as an outpatient, I know we've had a lot of conversations in our team meetings regarding this, and the physicians also in Medicare, annual Medicare visits, they do a pretty good amount of advanced care planning with patients as well. So they basically cover the outpatient side, and then I do a lot of the inpatient side, which, and I do complete those in accordance with the doctor. The doctor has to sign it, or the physician has to sign it. So, but yes, as of right now, it's basically just me helping folks on an inpatient basis, but I'm happy to answer any questions. So if anybody calls me and has questions or needs some guidance, I'm happy to help in any way that I can.
Okay, awesome. How would they reach you? Do you prefer email or?
So I'm more than happy to have you call me. Email gets pretty heavy. So um calling my office phone here at the hospital, which I guess I could have included that on here, but my
You
office number, do you want me to just go ahead and share that?
That's okay, or they could call the main line and ask
Yep.
for you too, right? So that, and then,
Absolutely. Yep. Yep. I am the only social worker. So if you call just the main hospital number and ask to talk to the social worker or Addison, they will get you up to me. And then I do have a direct office number as well that I'm happy to give out as necessary.
okay, Very good. Well, thank you. Gosh, you were excellent. This was an awesome program, and I feel like I learned so much from you. And I'm grateful that I mean, you've only been here at Boone County Hospital a few months, and I know you have a lot of extensive background behind you as well. So we're just so grateful to have your knowledge and your wisdom and expertise to share with us today. So thank you, Addison. And
Yeah.
if I don't see any questions in the chat. I think you did a great job of really covering some of those frequently asked questions and then maneuvering my minute over here a little bit more. So
Nope, you're fine. No, I'm
thank
I'm
you.
happy to help. And like I said, I'm very passionate about this. You can even ask any of our staff on the floor. I care about this stuff a lot. So I'm happy to help in any way that I can.
Yeah, it's very apparent, and we do appreciate that so much. And thanks again for being here with us today. And
Yeah.
we'll hopefully have you back again, maybe in next year sometime. So
Okay. Yeah,
thanks
thank
so
you.
much. Take care. Bye.
Thanks.
Bye.